The following program presents principles designed to promote good health and is not intended to take the place of personalized professional care. The opinions and ideas expressed are those of the speaker. Viewers are encouraged to draw their own conclusions about the information presented.
Hello and welcome to Health for a Lifetime. I'm your host, Don McIntosh, and today I'm just delighted to have Dr. Neil Nedley back with us. Welcome, Dr. Nedley.
Thank you. Good to be here.
I understand you're working on a new book that's a little bit depressing.
That's what the book is about, actually.
So maybe,
depression.
Maybe it's not depressing. Maybe it's how to deal with that. You maybe don't even have a title for the book yet, but you're working on that. It's coming out. Some of the things we're going to be sharing today will be in that book, either when they see this program or maybe a little bit after. What exactly is depression? I mean, lots of people have different ideas. When you say, I'm depressed, it could just mean you don't feel good that day. But what really is depression?
Well, depression is a sense of deep sadness. That's what most people equate depression with. But as far as in the medical community, we classify major depression as a disease entity. It's actually a mental illness, and it goes beyond just having an occasional blue Monday, even though it isn't Monday. It really goes beyond that to a disease.
So it's something that is actually verifiable. You can diagnose it. You can say, this is exactly what it is. It's not something else. This is what it is.
Correct.
And how do you go about that?
Well, we go about that by looking at the symptoms. Actually, depression, the diagnosis of depression is very much a part of the symptoms of depression. And if you have 5 of those 9 symptoms for more than 2 weeks, you are depressed. You fit the diagnosis of major depression.
Okay, so if you have your pen and pencil, you're going to tell us those, aren't you?
That's right.
So maybe you can repeat them later too, but what are those 9 symptoms? And you said if you have 4 or more, 5 or more?
5.
Of these 9, then you have major depression if it's gone on for 2 weeks.
Correct.
Okay, what are they?
Deep sadness is one of them, or a feeling of emptiness. Some people will just feel emptiness inside and not really the deep sadness. But if that persists for more than 2 weeks, you've got one of the symptoms.
Okay.
Second symptom is that of apathy, where an individual just doesn't have the motivation they used to have. Doing fun things aren't really all that fun anymore, and just a general sense of a lack of purpose would fit under the apathy, which is the second characteristic. Third is agitation, and individuals here can actually have restlessness, or they might actually have a slowing of their body motions. This also counts as agitation. If you see someone walking, for instance, and they aren't walking with the
pep in their step, spunk in their trunk,
that could be that they're suffering from at least one of the symptoms of depression. Fourth symptom is sleep disturbance. Some individuals will be too sleepy and actually be sleepy throughout the day, want to sleep more at night, and then other people will have insomnia and not be able to sleep. Most people actually fit into the insomnia role, but some will have the hypersomnia, or too much sleep.
So if someone's sleeping a lot, they say, this is not fun, and you say, you're having fun, and they say, no. Didn't you used to enjoy this? Yes. And they are saying, you can sort of pick up on whether or not, if you knew the right questions to ask, whether or not someone's depressed.
That's right. That's one of the things I like to bring out, is that this doesn't require a psychiatrist or even a mental health professional or a physician to come up with this diagnosis. An informed layperson can actually diagnose people correctly with major depression, or even diagnose themselves.
So we have deep sadness, apathy, agitation, and sleep disturbances. Just one question before we go on. Deep sadness versus apathy, again, I don't know if I really understood that. Deep sadness, is that where they say, I'm just really sad, or How can you tell when someone's deeply sad?
Often it will be crying spells without apparent reason. That's one of the things I see in my office practice a lot. People will be there for another reason. They'll be talking about something. I'll ask them a few questions about how things are going, and then they lose control and they start crying, and they're embarrassed about it often. Of course, we have tissues there because this is a frequent occurrence in a doctor's office, and they wipe their eyes and I reassure them. But to me, they would be labeled with that deep sadness from that point.
Okay, deep sadness, apathy, agitation, sleep disturbances, what else?
Weight changes or appetite changes. Some individuals will feel a need to eat all the time and will actually gain weight, and others will lose their appetite, lose their sense of hunger, and actually not be hungry, and as a result lose weight.
Okay, so if they're heading for the refrigerator, they could be depressed, or if they're not, they could be depressed, but you have to look at the other symptoms. What's another one?
Another one is actually a sense of worthlessness. Individuals will actually feel like they don't have self-worth anymore. They won't feel useful to others. They will always be putting themselves down in regards to their attributes. And that is one of the more serious, but a real symptom of depression.
Why is it more serious?
Because that usually leads to yet another symptom of depression, and that
Okay.
is morbid thoughts. Once people get this feeling of worthlessness, some people, as they advance, will actually begin to get into the morbid thoughts where they're actually beginning to plan their demise or coming up with a suicide plan.
Okay, so any others?
Yes, lack of concentration
Okay.
is another. In fact, this is very common among depressed individuals. They will be indecisive. They will have a very difficult time in making a decision. The evidence is there. They can look at the evidence, but as far as making a decision based upon that evidence, they have a real rough time doing that, and they often relegate that decision-making process to others. And that is a very significant but very common symptom of depression.
So if you have 5 of these symptoms, that being deep sadness, apathy, agitation, sleep disturbance, help me out when I get wrong here, weight or weight loss, fatigue.
Okay, we didn't mention fatigue, but that is the 9th one.
Okay.
And that's the one that most people come to me as an internal medicine physician for. They're coming to try to find out, why am I so tired? Mm-hmm. And in the process, I start asking them other questions, and not always, but some of the people that come to me complaining of fatigue, the reason for it is they're depressed, and they haven't really recognized that. And then we have to give them that diagnosis, and then also find out why they're depressed, and then get them on the appropriate treatment program.
So 5 out of 9 for 2 weeks. But let me say, what if I just had my dog die, or I had a relative die, or I was in a car accident? Does that count?
That would count for situational depression.
Okay.
Situational depression normally resolves on its own. Given enough time after a grieving event, the depression and that deep sadness and emptiness goes away. With major depression, however, it does not go away on its own. At least most commonly it does not. And the only way it's going to go away is when we find the cause and get on the appropriate treatment program. And then it can be gone forever. You don't have to be depressed for life.
Okay, so there's good news. It's not all depressing.
That's right.
Okay, so once you diagnose it with one of the 5 out of those 9, or maybe just a sub situation where you're not really have full blown, but you have some of it. What are the real risk factors involved? I mean, is it in fact just a coping mechanism so that you don't burn yourself out when bad things are happening, or are there really downsides to having depression?
Oh, there are significant downsides to having depression. It would be bad enough, Don, if it just caused these things. I mean, living your life with deep sadness and emptiness is a sad state of affairs to be in. But unfortunately, it does much more than that. It increases the risk in men of having a heart attack. It increases the risk of both sexes if they're depressed after having had a heart attack. It increases their risk of dying from complications of their heart attack. It increases the risk of certain cancers. And it also increases the risk of stroke.
All of the 3 major killers in America, it increases the risk of those.
Correct. It will also increase the risk of actually having complications of diabetes even. And on top of that, of course, it increases the risk of suicide, which is one of the most devastating consequences of depression.
So you really shouldn't just say, Paul or Jane or Mary or Susie's going to work through this, let's just give them time.
No, unfortunately, if Paul or Mary or Jane or Susan have depression, they really need to find out why and get on an appropriate treatment program as soon as possible.
You mentioned suicide. Tell us a little bit more about that. How often do people that are depressed actually commit suicide?
Well, it's the 8th leading cause of death in America today, Don. 31,000 people every year in the United States die from suicide.
Wow.
And among those ages 15 to 25, it's the 3rd leading cause of death.
Why is it elevated in young people 15 through 25?
Well, that's a very good question. It actually has to do with some of the root causes of depression. The frontal lobe we are now finding out that the frontal lobe is the seat and the origin center of just about every case of major depression. And it takes 30 years for the frontal lobe to be fully developed in human beings. So the 15 to 25-year group hasn't had their frontal lobe fully
Not everything's
developed.
connected. All the sockets are not in yet.
Not
all the cylinders.
Not all the connections are there.
Okay.
And secondly, often the 15 to 25-year age group are on a lifestyle program that is further suppressing the frontal lobe. High entertainment television, a poor diet, not getting proper sleep. And then if they have a bad event happen, such as they break up with their girlfriend or something else bad happens, and then if they have a substance on board like alcohol, you put all those things together and you end up very commonly, unfortunately, with suicide.
So it's not connected, their frontal lobe, all the way it is. I mean, I'm not trying to say to the people that are watching today, hey, you're disconnected. But really, it's still coming together. And then if you compromise it through drinking, through smoking, through whatever those different things are, drugs, all that kind of stuff, and then you have a bad event, you just don't have the wherewithal to get through it.
Correct.
And so you say, I might as well just end it all.
Often that's what people do.
Sad. So, what should you do? And maybe we'll talk more about this, a little bit later in the program, and we'll start talking about it now. What should you do if you know someone who you believe is suicidal?
They need to get help, and they need to get help immediately. If anyone states that they want to die, they wish they were dead, those are code words for saying that they are contemplating suicide.
So you shouldn't just try and talk them out of it and say, oh, you'll be okay, not that kind of stuff.
No.
And so what do you mean, get help? Because most people listening would say, well, that's what it means. You just talk to them. What does it mean when you say get help?
Well, actually, at that point, they need professional help. They need to find out why they're feeling that way. And they also need to be on appropriate treatment for their depression so that they no longer feel that way. Now, it is true that many family members can help them through the process. One of the ways is by actually finding out what instills hope in them. The fact that they haven't committed suicide usually means that there is some hope, and then dwelling on those hope aspects of things, and then trying to get them to see when they're talking about this that they really need some help can go a long way in saving a life.
So what if they say, well, look, I hear what you're saying and whatnot, but I don't want to listen to you, and they're belligerent. I want you to answer that question. It looks like we're just about out of time for our break, but when we come back, what about the person who's not listening to their relatives? We've been talking to Dr. Neil Nedley. When we come back, he'll help us understand how to intervene if someone has that major depression and, in fact, they're suicidal. Join us when we come back.
Have you found yourself wishing that you could shed a few pounds? Have you been on a diet for most of your life, but not found anything that will really keep the weight off? If you've answered yes to any of these questions, then we have a solution for you that works. Dr. Hans Diehl and Dr. Eileen Ludington have written a marvelous booklet called Reversing Obesity Naturally, and we'd like to send it to you free of charge. Here's a medically sound approach successfully used by thousands who were able to eat more and lose weight permanently without feeling guilty or hungry through lifestyle medicine. Dr. Deal and Dr. Ludington have been featured on 3ABN, and in this booklet, they present a sensible approach to eating, nutrition, and lifestyle changes that can help you prevent heart disease, diabetes, and even cancer. Call or write today for your free copy of Reversing Obesity Naturally, and you could be on your way to a healthier, happier you. It's absolutely free of charge, so call or write today.
Welcome back. We've been talking with Dr. Neil Nedley about depression. But, you know, we had mentioned just before we went away that if someone is so depressed that they're suicidal, how do we intervene? What if they don't respond? I want to come back to that, but there were some interesting, what would you say, risk factors that set us up for depression that I think that we should cover, and then we'll come back to remind me if I don't remind you to come back to that question. But what are some of the risk factors? Who's more likely to be depressed?
Well, actually, as far as suicide itself, males are more likely to commit suicide. Females are more likely to be depressed, but males are 4 times as likely to commit suicide than females are.
Is that because do females attempt suicide more?
Females actually do attempt it more, but they're not near as successful on their attempts. Males, when they do it, they tend to really want to do it and get it done the first time. And so that's something to keep in mind. If you have a depressed male, often it can be, although it can be serious with females as well, often you need to take it a little more seriously in a male person.
Okay, so then what are some of the other risk factors besides being male?
Being under the influence of alcohol. Almost 50% of all suicides take place under the influence of alcoholic beverages. And
that makes sense.
Mind-altering substances, other drugs on board. And so that is something that we really need to pay attention to. And if those drugs weren't used, we would have a lot less suicide.
Again, the frontal lobe, you're saying they exit out. They can't really use their reasoning abilities.
Correct.
What else?
Unwillingness or refusal to seek help for their depression is actually a risk factor for suicide itself.
So that's the one we were talking about, that if they say, no, I'm not going to go get help, that's actually another risk factor.
That's a risk factor.
Okay.
That's right. Another one would be if the individual had a serious physical illness. The elderly actually commit suicide at a higher rate than any other age group, even a little higher than the 15 to 24-year age group. And that's because often they have a serious physical illness and they don't know how to cope with it, and they go ahead and commit suicide.
They say, might as well just get it over with.
That's their thought process, but unfortunately it's not a healthy thought process.
No, not at all.
And then homosexuality is actually a risk factor for depression, as is those that listen to heavy metal music. That has been shown now as a risk factor for depression.
How would that work? How would someone who is homosexual be a risk factor? Is that because of the way others in society relate to that behavior, or is that because of the behavior itself?
Probably a combination of those factors. Actually, the researchers who brought out homosexuality as a risk factor mentioned that those are 2 probable reasons, but the actual reason why it's a risk factor has not been completely unfolded.
And heavy metal, why is it that that's a risk factor?
Probably, again, because of what it does to the frontal lobe of the brain. Heavy metal music is quite a suppressant effect on the frontal lobe. And it can have an influence actually similar to alcohol on the frontal lobe of the brain.
Seems to me like country western music might be a little depressive. I always listen to that and go, oh, she left me, oh, he left me, oh, poor me.
Yeah,
that sounds kind of depressing.
It can be melancholy music, and who knows, we might find out that that's a risk factor as well. But the one that's been looked at closest is the heavy metal music up to this point. Okay,
so there are some of these risk factors that you really can do something about. What you listen to and what behaviors are involved in, those are important things. Anything else?
Those are the main risk factors for suicide. Obviously, all the risk factors for depression, of which there are even more we could get into, but being depressed itself, of course, is a risk factor for suicide.
Well, let me come back to that question.
Okay.
We've now learned that, you know, one of the actual risk factors is refusing help when someone says they're suicidal. What should you do then? I mean, so many times it's kind of a stigma to either admit that you are depressed and suicidal, or you don't want to be the bad guy, so to speak, when you're helping someone. What would you say to both those types of individuals, and what do you do?
Well, first of all, it's always better, if you can, to try to talk the individual into receiving help. Try to talk them into the benefits that they could gain from this, and the fact that they don't need to be worried about the stigma. Abraham Lincoln suffered from severe depression. Winston Churchill suffered from severe depression, but these individuals were able to actually harness the powers of their brain and get on a program that actually made them great individuals. So just because you're having severe depression or having suicidal thoughts and are seeking help for that does not relegate you to the dumps of society by any means. But there are, as you mentioned, there are people that no matter how you talk to them, they are going to say, I'm sorry, I'm not going to get help. Yeah, I want to end it all, and I want to end it all, and I don't want to have anybody intervene.
Mm-hmm. So what do you do then?
Then you have to be the bad guy. And being the bad guy will save a life, and you need to understand that. And by being the bad guy, you have to actually turn them in to a health professional. And that health professional or the law department also has to get involved. The health professional can contact the police. If they are a danger to themselves, then the laws of this land allow us to forcefully treat the individual, and that means that they are committed for a 72-hour period, at which point they are given the opportunity for help.
Okay, so this is the good way to be a bad guy.
That's right.
And we really should do that. Will they eventually come around and say you did the right thing most times? Or?
Most of the time, they will thank that person for saving their life down the road. They may not do it in the first week or two, but after they have gotten complete help and they're over their depression completely, which sometimes can take a few months, they will come back and thank you.
So take action now is really the word. If this kind of thing is happening and you've seen those symptoms, if they have 5 of the 9 different things and one of them is suicidal ideation or saying, I'm going to do that, they don't necessarily even have to have a plan, do they?
No, that's right. Some suicidal patients have not had a plan up until the minute before they committed suicide. They're contemplating it. They'll tend to tell somebody. Most suicidal victims will actually tend to tell somebody that they don't want to live anymore. But to ask them whether they have a plan or not does not necessarily tell you as to whether they're going to do it.
You should still follow through. Now I'm interested about the Winston Churchill and Abraham Lincoln, I believe, that you mentioned. You said that they had this problem, but they found ways to treat it or to live with it. What did Winston Churchill do? What did Abraham Lincoln do to find satisfaction or to, treat depression? I'm sure they didn't have the drugs back then that we do. What did they do?
No, there was no Prozac or Zoloft available in their day. Actually, what they did was to get on a reasonably good lifestyle program and a thinking process to actually get them over their depression. And we don't have all the details on what they did. Necessarily, but we do know that they were both students of the mind and students of thinking, and they were actually able to habitually get their minds off of the melancholy and deep depression. I mean, Abraham Lincoln went so far as to say that if what I felt were equally distributed to the rest of the human race, there wouldn't be one smile left on the face of the earth. I mean, that's how bad he felt, how deeply depressed he was. But yet he was able to overcome that and give the Gettysburg Address years after he had overcome depression. And so, and Winston Churchill, his father, thought he was going to, in fact, was quoted as saying that he would be an obscure individual who would never make it. He failed his entrance to college, his entrance exam to college a couple of times. Winston Churchill did. And ended up having quite a few problems before he overcame them. And so there is hope. And there's actually more hope today, Don, than there was back in those days. for depression. We now know so much more about it than we did back then. And we also have so many more ways of finding the actual root cause of the depression and then getting them on the appropriate treatment.
And let's come back to that in just a minute. We have about 3 minutes left, but I want to ask another question. What are the long-term effects of depression if it's not treated?
There's serious long-term effects. There's a loss of the hippocampus. This is the area of the brain that involves memory. And the longer you are depressed, the smaller that hippocampus will become. And the worse the memory will end up being, and even the opportunity for memory will go down. Osteoporosis can result from depression.
How does that work?
We're not exactly sure, but it probably results from the rise in the stress hormone levels. Cortisol, for instance, that occurs in depressed patients, and cortisol will get rid of bone mass. But osteoporosis actually can be a problem of depression. And then even the common headache, tension headache, you'd be surprised how many depressed individuals have tension headaches. In fact, a lot of headache people don't even recognize they're depressed. They may not have the deep sadness, but they have 5 of the other 8 symptoms. And they're actually suffering from depression. In order to get rid of their headache, we have to actually find out why they're depressed first.
So when they say, you know, it's all in your head, and if it's a headache, they really should get that tested out. It's not really even, maybe there's a little truth to that. Make sure and test out why it is that you're having those headaches. Maybe you are actually depressed.
I had a head elder of another church come to me who had been to 4 other physicians with severe splitting headaches, had to even be on narcotics for his headache. And when we got through the interview process, it was clear that he was depressed. He didn't recognize it. Fortunately, his wife was there. When I'd ask him, do you have feelings of worthlessness? He would say, oh, no. And then she would, in the corner, nod her head. And then I would talk it through with both of them. And then he'd finally admit he did have feelings of worthlessness. When we went through with it, his headache was caused by depression.
So this could be an indicator as well. Not something to toy with. Well, we have a less than a minute left, and you know, you're a Christian physician. Is depression a sin?
No. To be depressed is not a sin. Now, it can result from sins.
Okay.
But it doesn't always have to result from sin. You can be have depression even though you never sinned. Arguably, Jesus himself was a man of sorrow and acquainted with griefs. But in many cases in this world, it is a result of not following the laws of health, and through either eating, drinking, or lifestyle measures that have helped bring this about.
We've been talking with Dr. Neil Nedley. We've talked about depression and what it is. We hope this has helped you. Get in touch with us. Thanks for watching.